So let's revise endometrial cancer today. Endometrial cancer is the most prevalent gynecological malignancy worldwide, accounting for up to 50% of all gynec cancers. It can be of two types. Type 1 is estrogen dependent endometrioid adenocarcinoma, while type 2 is estrogen independent and includes serous and clear cell types. The incidence of endometrial cancer peaks at the age of 55 to 65 years. One of the most revolutionary change in the context of CA endometrium over the years is our molecular understanding of it. The Cancer Genome Atlas provided a risk stratification framework to prognosticate as well as guide personalized treatment. It divided CA endometrium into four subgroups. First one is the pole gene ultramutated variety, which has excellent prognosis. In the fourth subgroup, where the copy number variation is high, that means that there are multiple gains and losses of DNA segment, prognosis is bad. In the middle two groups, where either the copy number is low or there is microsatellite instability, the prognosis is intermediate. The most characteristic symptom is postmenopausal bleeding. How to diagnose cancer endometrium? By TVS? No. It's only for screening, and mind it, in type 2 variety, endometrium remains thin. Biopsy is confirmatory, but how? Again, a topic of debate. With the pupil, dilatation and curettage, or hysteroscopic guided. MRI again is not mandatory before surgery, which is the primary modality of treatment, but it is recommended in selected cases to assess the depth of myometrial invasion, cervical stromal involvement, and suspected extrauterine spread. CT or PET, again only for metastatic workup. And yes, what about the molecular markers, which we said have revolutionized the story of endometrial carcinoma? So remember, the molecular testing is not done for a biopsy specimen. Rather, it is done for the surgical specimen after hysterectomy. Next is FIGO 2023 staging, which is indeed difficult to understand and remember. So, we will divide it into two parts, stage 1-2 and stage 3-4. Stage 1 is confined to the uterus. Stage 2 means disease is invading into the adjacent tissues. In both the stages, first focus on C, which means aggressive pathology. 1C, aggressive pathology limited to endometrium. 2C, aggressive pathology invading myometrium. 1A is tumor involving less than 50% of myometrium. 1B, more than 50%. 1A1 means limited to endometrium only. 1A2, invading the myometrium but less than 50%. And 1A3 means that though the invasion is less than 50%, but the same side ovary is also involved. Stage 2 denotes invasion. 2A, cervical stroma invasion, and 2B, lymphovascular space invasion. Stage 4, you all know it means metastatic disease. But here again, to complicate it, it's divided into three substages. 4A means when bladder and bowel is involved, 4B when the disease has gone into the abdomen, and 4C when there are distant metastases. Now let's focus on stage 3. It means that the disease has gone outside the uterus but still is within the pelvis. 3A is involvement of adnexa and serosa. It is further divided into A1, A2, adnexa and serosa. 3B, vagina or parametrium. B1, vagina, B2, parametrium. And 3C, usually in all genital cancers, 3C is lymph node spread. So C1 is pelvic lymph node, C2 is para-aortic microscopic invasion. C3 is para-aortic macroscopic invasion. C1 actually is further divided into C1A and C1B, which stands for micro and macro invasion respectively. Let's quickly revise it. Stage 1, diseases limited to the uterus. Stage 2, invading disease. Red dots here show aggressive pathology. 2A, invasion to cervical stroma. Stage 2B, lymphovascular space invasion. Stage 3A is involvement of adnexa or serosa. 3B, vagina or parametrium. 3C, lymph nodes. 4A, spread to bladder or bowel. 4B, abdominal spread. 4C, distant metastasis. That's it. Surgery is the mainstay of treatment for all stages. For stage 1, the surgery is hysterectomy with BSO with nodal staging. For stage 2, hysterectomy, BSO, and with that steps of staging are combined. For stage 3 and 4, it is debulking or cytoreduction. Now difference is in the adjuvant therapy which is given. In stage 1 and 2, if the type is low risk, there is nothing else required. If the risk is intermediate, only RT is required, while if the disease is aggressive, chemoradiation should be given. Stage 3 surgery is always followed by chemoradiotherapy, while stage 4, you have to give palliative chemoradiation and supplement it with immunotherapy also in selected cases. What about the molecular diagnosis? So stage 1 and 2, molecular testing is needed? Yes, because it modifies staging and adjuvant treatment. In stage 3 and 4, it is required? Yes, but not for changing the treatment, only for prognostication. Hormonal therapy also helps in estrogen dependent cancer cases, especially in fertility sparing treatment, advanced or recurrent cancer, or inoperable, which is an early stage cancer, and inoperable because the patient is a poor surgical candidate. What hormones do we use? Progestins, aromatase inhibitors, selective estrogen receptor modulators, selective estrogen receptor degraders, which is experimental and rarely GnRH agonists. Follow-up after treatment is equally important. For first 1 to 2 years, it is every 3 to 6 months, 3 to 5 years, every 6 months, and after 5 years, it can be done once in a year. To summarize, endometrial cancer typically presents with postmenopausal bleeding. It is broadly classified into type 1 and type 2. Diagnosis is confirmed by endometrial biopsy and staging is surgico-pathological as per FIGO 2023. Treatment includes surgery as mainstay of treatment with risk-based adjuvant therapy. Molecular classification guides prognosis and individualized management.